My name is Rodger Elble. I am a neurologist and movement disorder specialist at Southern Illinois University School of Medicine, and it is my pleasure to review the clinical characteristics and management of essential tremor. I have several disclosures. I consult with several pharmaceutical companies in the design of clinical trials for essential tremor, and I am a paid reviewer of videotaped examinations that have been performed in clinical trials. I am also on the Medical Advisory Board of the International Essential Tremor Foundation, and I receive research grant support from the Neuroscience Research Foundation of the Illinois Eastern Iowa District of Kiwanis International. All of these disclosures pertain to my research in essential tremor, but none represents a conflict of interest in this lecture. In this lecture, I will provide an overview of the new tremor classification scheme developed by the Tremor Task Force of the International Parkinson and Movement Disorder Society. I will demonstrate the use of this classification scheme in the diagnosis of essential tremor and essential tremor plus. I will discuss the importance of rigorous tremor classification when selecting and treating patients with stereotactic neurosurgery. Finally, I will briefly summarize the treatment of essential tremor. The new tremor classification scheme of the Movement Disorder Society has two axes of classification. Axis 1 is based on clinical features and Axis 2 is etiology. This is the same approach used in the classification scheme for dystonia. Axis 1 classifications are based almost entirely on the clinical examination. The characteristics of tremor and other clinical signs will usually reveal a well-known tremor syndrome, such as essential tremor. Tremor syndromes are defined by clinicians for the purpose of identifying the etiology and optimum treatment. In other words, the identification of an Axis 1 tremor syndrome is merely the first step and most important step toward finding a specific etiology and appropriate treatment. There are two basic categories of tremor syndromes in the new classification scheme. Isolated tremor syndromes consist of tremor and no other neurological signs or systemic signs or symptoms that are relevant to the patient's tremor. A combined tremor syndrome consists of tremor and one or more additional relevant signs or symptoms. Axis 2 etiologies include those that are acquired and those that are genetically determined. Unfortunately, the etiology in most patients is unknown, and this is certainly true for essential tremor. Nevertheless, these idiopathic cases often have historical clues that suggest an inherited disorder, and this is clearly the case for essential tremor. Axis 1 syndromes should not be confused with the types of tremor produced by various activation conditions. These types of tremor are neurological signs, and in general, one or more signs comprise a clinical syndrome. Tremor may occur at rest or during any action that requires the voluntary activation of muscles. Rest tremor is defined as a tremor that occurs when a patient is trying to relax and is given ample opportunity to relax the tremulous body part. Patients with severe tremor commonly have great difficulty relaxing. Therefore, it is helpful to examine patients in a supine position with the entire body supported by an examination table. Action tremor occurs when a patient moves, actively maintains a posture against gravity, or performs an isometric contraction such as gripping the handle of a tool. These three types of action tremor are called kinetic tremor, postural tremor, and isometric tremor. Most action tremors occur in a variety of postures and movements. However, occasional kinetic tremors occur only during a specific task, such as writing, and these tremors are called task-specific kinetic tremors. Postural tremors that occur only in a specific posture are called position-dependent postural tremors. Task-specific kinetic tremors and position-dependent postural tremors are regarded by most experts as probable signs of dystonia. Intention tremor is a form of kinetic tremor. Intention tremor is characterized by a crescendo increase in tremor amplitude as the limb approaches its target. Most intention tremors are due to a disturbance in the cerebellothalamic pathway. Professors Hopfner and Deutschel have published an excellent video tutorial on the examination of tremor, and I have cited this paper at the bottom of this slide. There are 4 categories of Axis 1 clinical features: historical features, tremor characteristics, associated signs, and laboratory features. These Axis 1 features are similar to those in the dystonia classification scheme, except for the inclusion of laboratory tests. The tremor classification scheme also emphasizes the concept of soft signs. Soft signs are questionable neurological signs of uncertain diagnostic significance, such as a mild head tilt or peculiar hand postures without definite evidence of dystonia. The laboratory studies in Axis 1 are studies that aid in defining the tremor syndrome, not in identifying a specific etiology. An example would be EMG frequency and coherence analysis in the electrophysiologic diagnosis of primary orthostatic tremor. Currently, there are relatively few useful laboratory tests. Electrophysiologic studies are helpful in distinguishing enhanced physiologic tremor from essential tremor because the frequency of essential tremor does not change more than 1 Hz when large inertial loads are attached to the affected limb. The methodology for this test is nicely demonstrated in the video tutorial published by Laungardner and colleagues. Also, dopamine transporter imaging is helpful in distinguishing tremor-predominant Parkinson disease from advanced essential tremor plus rest tremor. Like EMG, dopamine transporter imaging is not a test for specific Axis 2 etiologies. Here are some examples of isolated tremor syndromes and combined tremor syndromes. I would like to point out one source of possible confusion. In the tremor classification scheme, tremor with dystonia is considered to be a combined tremor syndrome. In the dystonia classification scheme, tremor is accepted as a common feature of dystonia, so tremulous dystonia without other signs is classified as an isolated dystonia syndrome. The tremor syndromes in this slide are well known to neurologists and neurosurgeons. However, the Axis 1 classification scheme also provides a framework for the definition of new clinical syndromes. It is important to remember that an Axis 1 syndrome is useful only if it is defined and used consistently by clinicians and researchers. An important clinical concept is that an Axis 1 syndrome can have multiple Axis 2 etiologies, and an Axis 2 etiology can produce multiple clinical syndromes. In other words, patients with the same syndrome may have different Axis 2 etiologies, and patients with the same etiology may exhibit different syndromes. This concept is illustrated for the classic Parkinson syndrome of rest tremor, rigidity, and bradykinesia. Multiple genetic etiologies of this syndrome have been found, and each of these etiologies is capable of producing additional syndromes or phenotypes. This is illustrated here for triplications of the alpha-synuclein gene. In the new classification scheme, essential tremor is simply an axis 1 syndrome, not a specific disease. Essential tremor is defined as a syndrome of bilateral upper extremity action tremor of at least 3 years duration, with or without tremor in other locations. Tremor is frequently present in the head and voice, but tremor in these locations is typically mild compared to the upper extremity tremor. In contrast to previous definitions of essential tremor, isolated tremor in the head or voice is no longer considered a variant of essential tremor. Furthermore, head or voice tremor is likely to be dystonic when these tremors are far more severe than the upper extremity tremor. The new definition requires a history of tremor for at least 3 years. This was done to increase the odds of a stable phenotype. Tremor of less than 3 years duration is called indeterminate tremor. The definition of essential tremor excludes other neurological signs such as dystonia, ataxia, and Parkinsonism. The Tremor Task Force introduced the classification of essential tremor plus to encourage careful, comprehensive phenotyping of patients. Essential tremor plus is used when a patient meets all of the criteria for essential tremor but has one or more neurological signs of uncertain significance or relevance. Examples of these so-called soft signs are listed here. Note that the presence of rest tremor or questionable rest tremor is no longer permissible in the classification of essential tremor. Therefore, essential tremor with rest tremor is a form of essential tremor plus. This new classification strongly encourages the documentation of subtle or questionable signs that may be relevant to the etiology and pathophysiology of tremor. It strongly discourages the old practice of sweeping these signs under the carpet of essential tremor. Additional research is needed to determine how clinicians judge the significance of such soft signs. A single soft sign might have little or no clinical significance, whereas multiple soft signs or specific combinations of soft signs may be very important clinically. We will return to this concept in a few moments. Essential tremor appears to have complex polygenic inheritance in most patients. The additive heritability of essential tremor is estimated to be at least 75%, so environmental factors appear to play a minor role, if any. Only rare Mendelian dominant mutations have been found in a few families with essential tremor. Essential tremor, and more commonly essential tremor plus, can be an early phenotype of hereditary dystonia, ataxia, and Parkinson disease. These phenotypes eventually evolve into more complex tremor syndromes. Such patients are then defined by their new phenotype and are said to have antecedent essential tremor. Here is an example of how this new classification scheme works. This patient initially exhibits isolated bilateral upper extremity tremor of 1 year duration. There is a strong family history, but the underlying genetic abnormalities are unknown. This patient is therefore classified as having an indeterminate tremor, not essential tremor, because the duration is only 1 year. The Axis 2 classification is idiopathic familial. 2 years later, the patient exhibits action tremor in the upper limbs, and she also exhibits action tremor in the head and voice. The Axis 1 classification scheme becomes essential tremor because she now has a 3-year history of tremor. The Axis 2 classification is still idiopathic familial. 3 years later, she exhibits increased tremor but now has a strained voice and a slight head tilt. However, the presence of dystonia is uncertain. She is therefore now classified as essential tremor plus, and she is said to have antecedent essential tremor. The Axis 2 classification is still idiopathic familial. 1 year later, her tremor is increased, her voice is still mildly strained, but she has definite cervical dystonia. Therefore, her Axis 1 classification becomes a dystonic tremor syndrome with antecedent essential tremor. Genetic testing reveals an octamine 3 mutation, so our Axis 2 etiology is now an octamine 3 mutation. The strict definition of essential tremor and the new emphasis on soft signs in essential tremor plus have already had an impact on clinical diagnosis and research. Experts have reviewed previous diagnoses in the context of the new classification scheme, and they have found that many patients previously classified as essential tremor are now reclassified as essential tremor plus. In this cohort of 283 patients with lower extremity tremor, 133 patients were originally diagnosed with essential tremor. Using the new classification scheme, 110 patients were reclassified as essential tremor plus, and only 20 of the original 133 patients retained the diagnosis of essential tremor. Here are some data from my own practice. During a 7-year time span, 34 patients underwent deep brain stimulation surgery for what was loosely defined as essential tremor. Using the new classification scheme, 20 of these patients actually had essential tremor plus. The reasons are listed in the table. In the future, it will be very important to determine how soft signs relate to long-term outcome in patients undergoing stereotactic surgery for essential tremor. Most surgical patients will have essential tremor plus, not essential tremor. And the most common soft signs appear to be those that are related to dystonia, ataxia, and Parkinson's disease. It is reasonable to ask whether the added diagnostic complexity of essential tremor plus makes any difference. There is already evidence that it does. In this study, quantitative spiography revealed subtle signs of upper extremity ataxia that predicted early tolerance to deep brain stimulation. In other words, patients with an ataxia subtype of essential tremor plus had a different long-term outcome than patients with essential tremor. In this study, 2 patients with subtle signs of dystonia and 1 patient with subtle ataxia of gait experienced disabling dystonia as a complication of thalamic deep brain stimulation surgery. It is possible that certain subtypes of essential tremor plus are more likely to develop maladaptive responses to surgery. and this certainly needs to be studied. Inter-rater agreement on the identification and interpretation of soft signs appears to be poor, but data on this topic are limited. In a study of Rajan and co-workers, greatest disagreement occurred in the interpretation of subtle or questionable signs of dystonia. For example, some clinicians regard spooning of the hands as a sign of dystonia. Spooning consists of flexion at the wrist and hyperextension of the metacarpal phalangeal joints. Large studies of controls are needed to determine the validity of soft signs such as spooning. It is clear from this old photograph that spooning can occur in normal people. This photograph was taken at a dinner party after the first meeting of the Tremor Investigation Group in 1990. We posed with this so-called wing-beating posture because there was considerable debate about its value in the assessment of postural tremor. We ultimately concluded that this posture was very valuable. The arrows point to spooning posture of the hands in two of my colleagues. Vives Rodriguez and Lewis studied this soft sign in 50 adults with craniocervical dystonia, 50 with Parkinson disease, 80 with essential tremor, and 70 controls. It is clear that this so-called finger-pointing sign is not diagnostically useful by itself. But this sign, in combination with other soft signs, could prove useful. More studies of this type are needed. The new classification scheme permits the definition of essential tremor subtypes. This is true for essential tremor and any other Axis 1 syndrome. Subtypes are usually defined in an effort to reduce etiologic heterogeneity in a population of patients. It is reasonable to consider any one of these subtypes of essential tremor. However, data from one subtype may not be applicable to other subtypes. For example, there is growing evidence that essential tremor beginning after age 65 is different from essential tremor beginning earlier in life. For this topic, I refer you to the paper by Hopfner and co-workers. David Marsden suggested two essential tremor subtypes that he called type 2 and type 3, and both of these subtypes are still relevant today. It is clear from epidemiologic studies that type 2 essential tremor is the most common form of essential tremor in the general population. These patients are mild and usually have a strong family history of tremor. Their tremor is very slowly progressive, and most people with this condition have not seen a physician for their tremor. Marsden's type 3 essential tremor consists of patients with greater tremor severity, often without a family history, and there is relatively rapid progression. These are the patients most likely to be referred for stereotactic surgery. The woman on the right was a legitimate surgical candidate when I saw her at age 34, and obviously she now needs stereotactic surgery very badly. In case you're wondering, Marsden's type 1 essential tremor was actually enhanced physiologic tremor, and Marsden's type 4 essential tremor was an action tremor resembling essential tremor that occurred as a part of other neurological syndromes such as Parkinson's disease. These two types of tremor are no longer considered to be within the realm of essential tremor or essential tremor plus. But these historical classifications illustrate just how broadly essential tremor was viewed in the past. Axis 1 clinical syndromes are based largely on the patient's history and neurological examination, and the importance of a thorough, skilled clinical examination cannot be overstated. There is still room for refining the clinical characterization of tremor, and I will now provide a few important examples. The characteristics of rest tremor have unique features in Parkinson syndromes. Rest tremor in Parkinson disease is suppressed during posture and movement initiation. This is a very specific sign of nigrostriatal dopaminergic degeneration or pharmacologic blockade. Severe rest tremor in Parkinson disease will transiently subside and then re-emerge if a posture is maintained for an extended period of time. I would also point out that rest tremor commonly occurs in the lower limbs of Parkinson patients, but rarely occurs in patients with essential tremor plus. Rest tremor is not suppressed by voluntary muscle activation in patients with essential tremor plus. This is illustrated in the videos of two patients with no bradykinesia or rigidity. Both patients had normal dopamine transporter imaging. Notice that these patients also have very asymmetric upper extremity tremor. Both patients have suspicious posturing of the hands, and the woman has a mild head tilt. The woman's head tremor also persisted at rest. These clinical features are suggestive of dystonia. Here's a list of other tremor characteristics that are believed to be useful in distinguishing essential tremor from other types of tremor. However, clinicians differ in the identification and interpretation of these signs. Consequently, these characteristics of tremor need to be operationally defined using data from large samples of patients and controls. Electrophysiology and motion analysis are being explored as tools for quantifying these characteristics. I will now briefly summarize the treatment of essential tremor, and I will emphasize how the new classification scheme can influence the interpretation of clinical data. Here is a list of recent review articles. I am listing these references here rather than cite them individually during the remainder of my talk. Everything that I say from this point on is documented in these references or in additional references that I provide in the following slides. There have been several evidence-based reviews of the treatment of essential tremor. All have found that only 3 medications have good double-blind placebo-controlled evidence of efficacy. Propranolol, primidone, and topiramate reduce postural tremor by approximately 50%, and they are less effective for kinetic tremor. The magnitude of effect is not adequate for most patients with moderate to severe tremor. Remember that 80 to 90% of patients with essential tremor have not seen a physician for their condition. Most of these people have tremor that is relatively mild. Nevertheless, most of these people have significant disability and might benefit significantly from one or more of these medications. For someone with mild to moderate essential tremor, a 50% reduction in tremor amplitude will have significant impact on quality of life. For example, a 2-centimeter hand tremor will interfere with many fine motor tasks, and a reduction to 1 centimeter will be quite significant for most patients. By contrast, a severe 10-centimeter hand tremor will still be severe and very disabling if it is reduced by 50%. Before discussing surgery, I would like to bring your attention to a problem in the manner in which the results of clinical trials are reported. In this table by Wong and co-authors, the percentage improvement from deep brain stimulation surgery ranges from 23% to 87%. This broad range and the low percentages are the consequence of computing percentage change in clinical rating scales rather than actual change in tremor amplitude. Clinical rating scales are ordinal scales, and the percentage change in these scales is misleading. Here is another table summarizing the results from the same clinical trials. Notice that the percentage improvement is estimated to be at least 80 to 90% in each clinical trial. Deutschel and colleagues computed the percentage improvement using the Weber-Fechner relationship between clinical ratings and actual tremor amplitude as would be recorded with a linear motion transducer. An 80 to 90% reduction in tremor is what most patients experience when they undergo stereotactic surgery for essential tremor. I will now explain why this method of computing clinical improvement is more appropriate than percentage change in clinical ratings. Ernst Weber and Gustav Fechner were psychophysicists who found that human perception of a physical quantity was logarithmically related to the magnitude of the physical quantity. This psychophysical law was found to be true for the relationship between tremor ratings, which are basically human perceptions, and tremor amplitude as measured with linear motion transducers. An example is shown in this slide in which tremor amplitude is plotted versus tremor rating. The relationship is clearly logarithmic. This relationship has been found for multiple transducers and has been documented by many investigators, and I refer you to my editorial review cited under the heading of this slide. The Weber-Fechner relationship between tremor amplitude T and clinical rating R is shown on the right. For a 0 to 4 rating, various investigators have computed a slope alpha ranging from 0.4 to 0.6 and a y-intercept beta ranging from -1 to -3. From this equation, one can derive the equation for change in tremor amplitude as a function of change in tremor ratings. So now let's assume a value of 0.5 for alpha, which is pretty typical. And let's consider a tremor rating that decreases from 4 to a rating of 2. This is a 50% reduction in tremor rating. But note from the calculation using the Weber-Fechner relationship, there is a 90% reduction in actual tremor amplitude. This method of computing improvement was used in my review of stereotactic surgery published 2 years ago. To be conservative, I used a slope alpha of 0.4. This method can be used for any rating scale, but the slope alpha must be adjusted for the number of points in the scale. For example, for the 10-point spiral rating scale of Bain and Finley, the slope alpha is 0.2, as shown in the equation at the bottom of this slide. This slope is exactly what Dietrich Halbenberger and colleagues computed empirically in their 2011 paper in movement disorders. A complete review of stereotactic surgery is beyond the scope of this talk. Here I will focus on a few areas of controversy. One area of controversy is the safety of bilateral surgery. The consensus opinion is that deep brain stimulation is the preferred procedure for bilateral surgery. Radiofrequency ablations are rarely done today. This procedure has been largely replaced by incisionless methods of MR-guided focused ultrasound and radiosurgery. I have reviewed this literature twice for two different publications, and I must say that the risks of these procedures vary greatly among publications. The problem is that the adverse events in most published studies were not documented and collected prospectively. Therefore, the reported incidence of adverse events is subject to recall bias. Here I will refer you to the recent review by Dalla Piazza and co-authors. I would point out that even for deep brain stimulation surgery, the risk of significant adverse events increases greatly when bilateral procedures are performed. For this reason, some proponents of MR-guided focused ultrasound and radiosurgery argued that these ablative procedures may be as safe as deep brain stimulation. Suffice it to say that the relative safety of these procedures is unclear. Very few centers have experience with all of these methods. Another topic of controversy is the relative efficacy of deep brain stimulation, MR-guided focused ultrasound, and radiosurgery. The published literature provides no conclusive evidence that one procedure is more effective than the others, and any difference in efficacy appears to be so small that it would take a very large controlled study to demonstrate statistical significance. When discussing efficacy, other topics of controversy arise. One is the optimum target for stereotactic surgery. Is the optimum target the ventralis intermedius, or is it the posterior subthalamic area? And within the posterior subthalamic area, is the optimum target the cerebellothalamic tract or the caudal zona incerta? To my knowledge, there is only one controlled study, and this study found that there is no significant difference in efficacy for deep brain stimulation in the ventralis intermedius versus the posterior subthalamic area. However, this study and others found that the posterior subthalamic area might be a more efficient target in terms of the stimulation parameters needed to control tremor. The optimum target might vary among subtypes of essential tremor and essential tremor plus, so the new classification scheme will play an important role in future research. Also, there is a need to study whether various subtypes might benefit from novel stimulation protocols for maximizing efficacy, minimizing side effects, and reducing the incidence of tolerance and maladaptive response. Ventralis intermedius and the anatomical structures of the posterior subthalamic area are very small and very compact. It is therefore very difficult to selectively stimulate or ablate ventralis intermedius, the posterior subthalamic tract, or the caudal zona incerta. The volume of tissue activation shown here in light blue typically extends 1 to 3 millimeters beyond the electrode, which is roughly 1.3 millimeters in diameter. Consequently, it will be very difficult to prove one target more beneficial than the others. Nevertheless, I believe such studies are worthwhile as long as they are prospective controlled studies. Such studies need to capture and carefully document adverse events in a systematic, prospective manner. I mentioned the possible influence of stimulation protocols, but there are no controlled studies. There is evidence to suggest that lower pulse widths reduce side effects of electrodes placed in ventralis intermedius and in the posterior subthalamic area. In the early days of deep brain stimulation, patients were routinely instructed to turn their stimulators off at night in order to prolong battery life. There is now some evidence to suggest that the incidence of tolerance is reduced by turning stimulators off at night. This should be studied prospectively. Patients with tolerance frequently improve with relatively minor changes in electrode configuration or stimulation parameters, but the benefit is typically lost in a matter of weeks. Therefore, some experts recommend that patients alternate between different stimulation parameters and electrode configurations to reduce tolerance and maximize efficacy. It is unclear how frequently patients should do this. A typical time interval is 1 week. Many patients with tolerance have severe rebound tremor when their stimulators are turned off, and these patients may find alternating stimulation settings much more tolerable than turning the stimulator off. Finally, the benefits of directional leads and their impact on long-term efficacy need to be studied in a controlled double-blind fashion. Preliminary evidence suggests that directional leads and circumferential leads produce comparable reduction in tremor, but side effects are reduced with directional programming. Furthermore, the newer pulse generators that come with directional leads are capable of pulse widths less than 60 microseconds, and this may also be beneficial. I will conclude by summarizing several key points. First of all, the new classification scheme distinguishes clinical phenomenology from etiology, axis 1 and axis 2. Essential tremor is defined as an isolated tremor syndrome in axis 1. Essential tremor is not a specific disease or etiology. Essential tremor plus is used when a patient meets all criteria for essential tremor but has other subtle clinical signs of uncertain significance. Propranolol, primidone, and topiramate reduce action tremor by 50% or less. This is not adequate for most patients with moderate to severe tremor. Stereotactic surgery reduces tremor amplitude by at least 80 to 90%. Deep brain stimulation, MR-guided focused ultrasound, and radiosurgery appear to have comparable efficacy, but their relative safety and long-term efficacy are unclear. This uncertainty and the following questions need to be addressed in controlled studies. Relative safety of bilateral surgery, relative safety and efficacy of ventralis intermedius versus posterior subthalamic targets, relative incidence of tolerance and maladaptive responses to surgery, and advantages of low pulse widths, directional leads, stimulation holidays, and alternating stimulation settings. This concludes my lecture. I hope that you have profited, and I thank you for your attention. Please feel free to contact me at this email address.